santé. We will now begin. Nous allons maintenant commencer. Good evening. Bonsoir, Dr. Paul.
Good evening, everyone. Bonsoir tout le monde. Another week, very busy week, and I'm sure we have a lot of questions to start with. Just to say that we're getting ready for summer. Summer. I wish it was summer. Fall months, and I'm looking forward to answering some of your questions. Bonsoir tout le monde. On est à rentrée d'automne. Ça a commencé il y a quelques jours. Donc, j'ai hâte à répondre à vos questions. Je sais qu'il y a pas mal de questions. Donc, on va commencer.
Perfect. Thanks, Dr. Paul. So we'll get started right now with some questions we received earlier this week. So the first one is just related to some of the school guidelines. So there's still some questions about why there's a discrepancy or seem to be differences between some of the guidelines that we're promoting for the EOHU region, specifically with regards to siblings of a symptomatic family member. And why are these different than those from the guidelines that are being promoted by Ottawa Public Health?
Okay. That's a very good question, and it really speaks to, first of all, the East Ontario Health Unit region is Stormont, Dundas, Glengarry, Prescott Russell, and Cornwall. Essentially everything east of Ottawa along the 417 and everything east of Ottawa, just outside of Brockville, Iroquois, all the way to the Quebec border. So it's a big territory. So that's our territory that we cover. And health units are usually given direction, provincial direction, and we are actually obliged to customize or taper those directives to the local situation. So in this situation, the guidelines have several recommendations. One of them is during high peak, when you have a high kind of red zone type of levels of activity in the community, where you do one thing, and where you have lower levels of activity in the community, which is our situation right now compared to Ottawa, for example, you do another approach for those siblings, for example. So, I know that our sister health unit, which is Leeds Grenville, which is Brockville, Gananoque, and the Thousand Islands, they have the exact same protocols that we do, because we have similar situations and similar type of populations and so on. Whereas Ottawa has, as you know, is a hotspot in the province and has higher rates of infection. As a matter of fact, they had their highest case load ever a couple of days ago. And so it's a different situation. So they're following the protocol that applies to high infection rates versus the lower infection rates that we have. So that's what the difference is. But if you compare us to our health unit that has similar rates than us, that's what it is. Now, should we change? Should our health unit all of a sudden have a lot of cases, out of control cases, increasing and increasing daily, we will change the approach and we'll use what Ottawa is doing, because that's what the guidelines say. So that's what it is. Donc, au niveau, on a une question au niveau de différents politiques au niveau des enfants. Disons qu'un enfant est malade à la maison, est-ce qu'on restricte les proches, les frères, les sœurs, les parents de rester à la maison jusqu'à temps que les tests sont revenus? Donc, en temps normal, premièrement, le bureau de santé de l'Est d'Ontario représente la région du Prescott Russell qui commence à Rockland jusqu'à Hawkesbury, et SDNG, Stormont, Dundas, Glengarry et Cornwall qui commence juste à l'extérieur de Brockville et Iroquois jusqu'aux frontières québécoises à Bainville. Donc ça, c'est notre région. Et les protocoles de santé publique en général, n'importe quel que ce soit, est habituellement, on a l'obligation, en effet, peut les changer selon notre population, selon qu'est-ce que notre population démontre ou a besoin. Donc, dans le contexte de directif au niveau de qu'est-ce qu'on fait avec, disons, un enfant est à la maison, retour à la maison, il est malade, on a fait le test du COVID, puis en attendant, qu'est-ce qu'on fait avec les parents ou les frères ou sœurs? Est-ce qu'il peut retourner en attendant ou est-ce qu'il reste isolé avec l'enfant jusqu'à temps qu'on a les résultats? Donc, les guides, il y a deux types. Les guides dépendent de la situation autour de nous. Donc, en situation où on a beaucoup des cas hors de contrôle, comme Ottawa par exemple, parce qu'il y a beaucoup de cas, à ce moment-là, les protocoles disent que oui, ces enfants, ainsi les frères, les sœurs, les parents, doivent rester à la maison jusqu'à temps qu'on a les résultats. OK? Par contre, ils disent aussi que si on a on n'a pas dans un état épidémiologique au niveau de beaucoup des cas, des surcharges des cas, etc., comme on voit à Ottawa, on pourrait avoir une autre approche qui disent que oui, tant que les enfants qui sont proches, les frères, les sœurs ou les parents, ne sont pas malades, n'ont pas de symptômes, ils pourraient retourner au travail. En attendant, ils ne devraient pas être isolés avec l'enfant. Donc, c'est pour ça qu'on a, nous et Leeds-Grenville, qui est à Brockville, Gananoque, on a des régions, on est semblable au niveau des cas, on est semblable au niveau des démographies, etc. Donc, nous, on a le même protocole avec Leeds-Grenville, mais Ottawa, ils ont un autre protocole. C'est le protocole avec le premier scénario que j'ai parlé tantôt, c'est celui qu'on a beaucoup des cas ou des cas qui sont augmentants. Nous, on n'est pas dans cette situation. C'est pour ça qu'il y a une variance. Par contre, si, disons jamais que notre région va commencer à avoir des cas augmentants, comme on voit à Ottawa, à ce moment-là, on va changer nos protocoles.
Great, thanks, Dr. Paul. Can you, we have a follow-up question related to this topic. So Cynthia Morgan asks, so if a student lives in the EOHU region but goes to a school in Ottawa, how would that case be handled?
It would have to be handled in the health unit where the child, well, okay, repeat it again. If the child lives.
They live in the EOHU region,
Yes.
but they go to school in Ottawa.
Okay, so we had the other way. We had it with parents, so which is different. So if they live in the HU and go to school in Ottawa, they would have to follow the rules of that school, which is in Ottawa.
Perfect, thank you. So we'll move on to another question, and this has to do with some of the news that came out of British Columbia and where they've revised their symptom list for COVID-19, specifically related to kids. And so there's questions about, has there been any discussion about having a similar approach here in Ontario to shorten the list of symptoms for children and youth?
Definitely, there has been discussion. As a matter of fact, I brought it up to the ministry in Toronto when we found out about this, and we're looking at our statistics, and we know that a lot of the kids who now have runny noses and colds test negative. I would say most do actually, and so that because we have a lot of other viruses that are going around. So I know that there has been an approach where they've removed some of the symptoms, and we are definitely very seriously looking at it at a similar approach in our area as well. So stay tuned. I can't give you more details than that, but all I know is that we have discussed it with Public Health Ontario and the ministry, and they're looking into it. We're trying to look at what is the evidence and what is the best approach for that. But it certainly will make a big difference. I understand that. Donc, c'est une bonne question, celle-là. C'est parce qu'en Colombie-Britannique, ils ont enlevé certains symptômes, leurs enfants ont pour qu'ils puissent continuer à l'école. Autrement dit, si, disons, il y a le nez qui coule, il peut rentrer à l'école. Par contre, ici, même avec un symptôme, l'enfant doit rester à la maison. Donc, et la question était, est-ce qu'on prévoit d'avoir le même politique ici en Ontario? Et la réponse est oui, en effet. Aussitôt qu'on a vu que Colombie-Britannique a fait ça, moi, personnellement, j'ai parlé avec Santé publique Ontario. Ça, c'est nos experts scientifiques. Et on est en train de regarder l'évidence et une approche. Sûrement, ça va aider parce que je peux vous dire que la plupart des enfants qui étaient testés depuis le commencement d'école sont négatifs. Et puis, on voit, il y a des virus qui sont autour, qui ne sont pas le COVID, mais par contre, ils causent les mêmes symptômes. Donc, ce changement, je pense, va changer pour le mieux.
Fantastic. Thanks, Dr. Paul. So moving on to something I think that has been in the news. It's obviously over the last few weeks, we've seen an increase in the number of people needing a COVID-19 test. Mm-hmm. And most testing centers across the province and our region have been very busy. So yes. Can you tell us what measures are in place to make sure people who need to be tested can get tested and get their results in a timely fashion?
Yes. Two things. Number one, what will determine your test results? will be the laboratory capacity. So right now, the provincial capacity is probably around 38,000 tests a day. And and don't forget that in our area, the tests are all sent to Ottawa. So all the Eastern Ontario, Ottawa, all go to the Ottawa lab. So what limits it, so we can do a lot of tests, we can test a lot of people, but that there's a backlog in the labs. And I know that the government is working on it, and we will have an increase in the ability to test in the lab up to about 50,000 very shortly. So that's going to improve. Now, in terms of people wanting to get tested, yes, we're overridden by people wanting to get tested, and primarily in the past, if you look at what would happen over the last month and a half or two before that, we were actually seeing most of our people were coming in had no symptoms. They just wanted to get tested and not necessarily having contact with anybody. However, now what's happening is they continue to come, those people who had no symptoms and really no reason to get tested. But on top of that, now we've got a lot of people with colds because it's cold season, school started, and we started seeing a big demand by both sides, demanding. And that, as you said, it's not only here, but we see it in the rest of Ontario and Quebec, the rest of Canada, for that matter. And so what we've done is a couple of things. So I talked about the laboratory capacity. Now, in terms of the testing itself, we have now, because we're overwhelmed by those numbers, and I'll talk about specifics, but in general, over the last week and a half, we were encouraging people only with symptoms and only those sent by public health. For example, if you're sent by public health to get tested because you may have been in contact or, for part of our contact tracing, then we should be tested. So we would give priority to those. And we had that, we sent out a memo about a week ago to all of our assessment centers. Today, the government has actually issued a provincial, what's called new testing guidelines or new testing approach, where we're doing the exact same thing. So now we're asking people who are who have no symptoms, not to come to get tested. And they're now, as you've heard yesterday, there's 60 pharmacies in Ontario that will be offering, as of tomorrow, tests for asymptomatic people who have no symptoms. Now, there's about 13 in Ottawa, but there's none in our Eastern Ontario area. However, I had spoken to the head of the lab, the head of the labs, and I was told that it's coming in our area as well. So very shortly, we'll be able to have multiple places of going, and again, those pharmacies will help out in that regard. Now, in terms of locally, what we've done, we've had, as you know, we actually have 6 testing centers in our area, and we've had increases all over, particularly in our Castleman and Winchester areas. And we've had a lot of people coming, some people coming from people from Ottawa as well, because that's the closer to their area if they're living in that area. And so we've been overwhelmed. Our Castleman office has been overwhelmed. We did 450 cars last week, and it actually closed down the city because it was a very small road, and we don't have any room to put the cars that are waiting except on the road. So we're working with our police, and we've been overwhelmed doing that, and it's been very difficult for everybody. And I realize there's long lineups. So in response to that, what we're actually looking at creating another place for our testing centers. And we will be actually, as of today, temporarily, we put up some pop-up tents, some tents at the parking of the Calypso Water Park, right off the 417 in Limoges, where we can have long lineups of cars in the parking area, which is very big, and we'll decongest so people can go there and get tested as well. So now we're offering 2 drive-throughs at this point in time. This is a temporary measure so we can get people coming. And again, so that I think will help. And we're looking at our other areas as well what we can do in our region. But primarily in this area, this will be there. And it started today. It's actually testing without an appointment, drive-through, obviously, from 9 to 5 p.m., 9 a.m. to 5 p.m., 7 days a week. And this is going to be offered to anybody over the age of 1 year of age. So we'll do babies up, but 1 year of age and over. So I think that's going to start decongesting. As a matter of fact, it started today at noon. And I think that it'll help. So we'll temporarily. What our plan is that we will then move our Castleman testing center, because we're still overwhelming the roads there, to a more permanent solution at the Calypso parking lot. And so there is a few things that are going on. So I'm going to say that in French, and I hope I'll be able to repeat that in French. Donc, au niveau du testing, il y a deux problèmes. Un, c'est d'avoir accès pour être testé. Et deuxièmement, c'est l'attente, une fois qu'on a testé, l'attente des résultats. Premièrement, au niveau de l'attente des résultats, ceci n'est pas à notre contrôle, c'est plutôt les laboratoires, c'est la capacité de laboratoire. En effet, nous savons que actuellement, on peut faire 36 000 en Ontario par jour. À un moment donné, d'ici une semaine, ça va augmenter à 50 000. Donc, même si on fait beaucoup de tests, il va y avoir une attente, mais ceci va améliorer avec le temps. L'autre chose, c'est l'accès aux tests. Le fait qu'avant, il y a beaucoup de monde qui venait sans symptômes pour être testé, même sans raison. Et qu'est-ce qui est arrivé aussi? En même temps, surtout depuis quelques semaines, quand on a rentré à l'école, on avait des personnes qui étaient malades, beaucoup de personnes avec les grippes, les rhumes, etc. Le débit et la demande a augmenté. Ça surchargeait la plupart des centres de dépistage, incluant les nôtres, Ottawa, Toronto, même à Québec. Donc, pour répondre à ça, surtout dans notre région à Castleman, on a été débordé. On a fait 444 autos, je pense, la semaine passée, mais ceci a quasiment fermé Castleman. Castleman est un petit village avec une rue principale. Les autos étaient en ligne 2-3 km, presque au 417. Donc, ceci est dangereux au niveau du trafic et on ne peut pas répondre à toutes ces demandes. Donc, qu'est-ce que nous avons fait? C'est que nous avons des plans à déménager nos centres de Castleman au stationnement du parc Calypso, qui est sur le 417 à Limoges. Et ceci va être fait d'ici quelques semaines parce qu'il faut qu'on mette les trailers, les choses en permanence parce que c'est à l'extérieur. Mais entre-temps, dès aujourd'hui, à midi, on a mis un centre de dépistage au volant encore, à Limoges aussi, au Calypso. Et ceci va servir toute la région et ça offre les services 9 heures le matin jusqu'à 5 heures l'après-midi, 7 jours par semaine pour les personnes 1 an et plus. Donc, les bébés plus qu'un an et les adultes, etc., on le fait. Et ceci est en attendant qu'on déménage tout le bureau à Castleman là-bas, parce que Castleman, on ne peut pas avoir des centaines d'autos, ça bloque tout le village. Donc, ça s'en vient.
Excellent. Thank you, Dr. Paul. So a little bit more on testing. So there's some questions in the chat box, but something that was asked previously, again in the theme of trying to reduce the volume, but can you update us on whether there are any plans to look at different testing measures in schools? So whether, for example, we're looking at doing on-site testing in schools or looking at a rapid test, such as the mouthwash or spit test instead of a swab?
Okay, excellent questions. First of all, as is now, we have teams. So let's say, like we had a couple of schools that had some kids that were some people positive in some schools. There weren't outbreaks. So let's say we wanted to get, for some reason, a couple of kids tested. Well, they would go to the nearest assessment center. They'd give them, and we test them there. But let's say we had to go and test a school or a classroom. We have a team of paramedics that will actually go and displace themselves because we don't want 30, 40 kids or 50 kids or whatever teachers going to the assessment center. So yes, we do have those protocols in place. That's number one. Number two, there are, I think there is a light at the end of the tunnel where it comes to testing. Several things. There's going to be the saliva test, but I want to clarify it. The saliva test that's in BC, and actually we're actually piloting now in Toronto in 3 centers. You basically gargle with salt water and then you spit into a little glass, and then that glass is sent to the laboratory. It's not an instant test, that one, but that will be available. That will make life easier for people. You don't have to put swabs in or anything like that. So that's number one that's coming. Number two, and the other thing too is, in terms of swabbing, now we have different procedures. We can have like a nasal swab and a sort of a throat or cheek in the inside, which is easier than having the nasal pharyngeal swab, which goes to the back of the nose through the nostril, right, which is uncomfortable. So those things are coming. However, what I'm excited about, and I'm hoping that we can get Health Canada approval, is something that is a more rapid test. So when you take a swab, let's say, you would have a little machine or a little computer-like apparatus. You'd put the swab in, and within 15, 20 minutes, maybe even half an hour, you get the result. So there are 5 of those that are now being commercially made, but not licensed in Canada because they have not been approved by Health Canada, and they're being approved. The process is being done now, and I'm hoping to be able to get some kind of response from Health Canada, not myself, but all of us, and that's going to change everything. Where we'll be able to go, and just do the test very quickly, put it in a machine, get your result, and don't have to wait for it. And that, to me, is going to be a game changer when it comes to that. So there is going to be some refinement in those testing, and I'm hoping sooner rather than later. En français, je veux dire, parce que la question était plutôt, est-ce qu'on a différentes modalités de tests, des tests rapides, etc. Il y a un test de salive qui se fait à Colombie-Britannique. Qu'est-ce qu'on fait ici à Ontario? C'est une bonne question parce qu'il va y avoir des changements. Déjà, en Colombie-Britannique, on a un test de laquelle on pourrait prendre une gorgée de l'eau salée et crache dans un petit pot. Le pot est envoyé au laboratoire au lieu d'une swab, un dépistage du nez. Et ceci, donc, vous pouvez voir que c'est beaucoup plus facile à faire le test. Mais il faut aller au laboratoire, il faut attendre le même temps parce que c'est à peu près le même processus qu'ils vont prendre au laboratoire qu'ils vont faire pour une prise du nez. Mais et aussi, donc, ce test de salive n'est pas instantané. Il faut aller au laboratoire, mais le procurement, le prélèvement est beaucoup plus facile. L'autre chose qui arrive, c'est qu'on est en train, il y a 4 ou 5 compagnies qui ont des unités dans laquelle on fait un test, on prend un prélèvement, on le met tout de suite, et puis on a les résultats en dedans de 15-20 minutes. Donc, on appelle point of care testing en anglais. Et il y en a 5 qui sont en train d'être évalués par Santé Canada. Et j'espère que très bientôt, on va avoir une qui a été approuvée ou quelques-unes qui ont été approuvées pour qu'on puisse utiliser. Donc, ça va changer complètement la façon qu'on diagnose et on isole les personnes parce qu'on va savoir les résultats quasiment tout de suite. Donc, ça va changer beaucoup. Et je pense que je suis optimiste, mais dans les prochaines 4 à 6 semaines, on va avoir de nouvelles dans cet aspect.
Fantastic. Thank you, Dr. Paul. We're going to move on to talking a little bit about flu season. As you mentioned, we're into fall. And so we have some questions about whether or not you're able to give us a bit of an update on when the influenza vaccine will be available to members of the public and where they'll be able to get it.
Okay. Good question. First of all, just before I answer that, I just want to talk about the flu itself. As you know, the flu and COVID are similar symptoms. And so, and you don't want to get both because now they're going to crash at some point. So we are recommending highly for people to get the flu as part of our COVID strategy for a couple of reasons. Number one, because the symptoms are the same, if we have less people with flu symptoms because they have the flu shot, less people are going to be going to the hospital, less people are going to be going to get tested. So it's going to be less burden on the system. And don't forget, it's the same people in the hospital who are doing the testing, who are treating COVID patients or treating flu patients. So the less flu we have, the more free these people can do their COVID work and actually their regular hospital work, particularly in the hospitals. So that's the first thing. So that's why we recommend this year, particularly to get the flu shot. Now, the flu shot will be delivered to health units next week. And what we do as usual, we distribute it to long-term care facilities because those are the more vulnerable populations. And then the first week of October to the second week of October, we will then have a bigger batch, which will be distributed across our area to family doctors and so on, and pharmacists will get it as well. Now, this year is more of a bit of a challenge because we can't put a lot of people in a room, because usually what happens is doctors have, you know, a full waiting room and they vaccinate, you go home and so on. We can't do that because of COVID, so it's going to be a bit different. So some doctors may not be able to vaccinate as many people. Same thing as the pharmacies. Pharmacies might require an appointment, a different approach, not walking anymore. So it'll be available in that way, a different way. So you have to, you know, you'll have to isolate, masking, and so on. And you can imagine, because we have distancing, you can't put as many people waiting at the same time. So so we're looking at different creative things. There might even be drive-through vaccines in certain areas. And also in our area specifically, it'll be available through doctors' offices. It'll be available through family health clinics and so on, community health centers, those type of things. It'll be available at area pharmacies as well, but again, a bit different than usual. It might be by appointment, because it's different, and it'll be available in all 6 of our health unit offices. And what we're trying to do is we're trying to gauge how many physicians are not going to be giving it, so we can make up. And we're going to be having clinics regularly by appointment, even on weekends, in all our 6 offices, to be able to provide these vaccines to everybody. So it's going to be a bit different this year, but we still think that we can vaccinate as many people as possible, and I urge you to get vaccinated this year. La question est reliée au vaccin antigrippal. Comme vous savez, à chaque année, on reçoit le vaccin. Nous, cette année, on va le recevoir, quand on dit nous, la santé publique, parce que c'est nous qui distribuons local. On va recevoir nos vaccins. Au début, on reçoit peu de quantité, assez pour donner aux maisons, aux foyers à longue durée, etc. Donc, ceci va commencer début octobre. Début octobre, on commence à recevoir beaucoup plus de vaccins qui vont être acheminés aux médecins partout. Même chose, ils vont aller aux pharmacies aussi. Donc, mi-octobre, le vaccin va être disponible soit aux cliniques médicales, au centre médical, au bureau de santé ou aux pharmacies. Mais ça va être différent cette année parce que d'habitude, il y a des médecins, il y a des cliniques spéciales. On a la salle d'attente qui est pleine, une à la fois on le vaccine, puis on va à la maison, mais on ne peut pas le faire parce qu'on ne peut pas mettre tout le monde. Il faut avoir l'isolement, il faut avoir la distance physique, il faut avoir les masques, etc. Donc, le débit va être beaucoup différent cette année. Ça va être sur rendez-vous pour ne pas avoir des fils, des longs fils, etc. Donc, ça va être différent. Au niveau de bureau de santé aussi, nous allons travailler avec rendez-vous, c'est ce qu'on fait depuis quelques années, depuis que les pharmaciens ont des vaccins. Et à ce moment-là, on va offrir le vaccin par rendez-vous, mais vraiment 6-7 jours par semaine à tous nos 6 bureaux. Donc, pour être convenient pour tout le monde. Donc, je vous prie de vous faire vacciner parce que ceci fait partie du COVID, parce que quand vous voyez, mois d'automne, on a COVID et on a l'influenza. Les deux ensemble, ça va être difficile. Donc, les deux symptômes sont les mêmes. Donc, si on a le plus de personnes qui sont vaccinées contre la grippe, le moins de personnes qui vont avoir des symptômes d'influenza qui ressemblent le COVID. Donc, ils n'auront pas besoin d'aller à l'urgence ou d'aller se faire tester. Donc, ça fait partie du protocole contre le COVID en automne. Et aussi, il faut comprendre aussi que si on a beaucoup de personnes malades avec l'influenza, ils vont surcharger l'hôpital. Et si on a une augmentation des cas de COVID, les deux vont surcharger les hôpitaux. On ne veut pas que ça soit fait. On veut que les hôpitaux soient capables et prêts de traiter les personnes COVID ou faire des autres choses, les opérations, des choses comme ça.
Excellent. Thanks, Dr. Paul. So we have a bit of a follow-up on this. Somebody's wondering why we would continue to be promoting the flu shot when the current COVID measures of, physical distancing, hand hygiene, wearing a mask should, in theory, also work at helping to prevent propagation of the flu. So just wondering if you have any comments on that.
Well, yes, I do. We do know that it will decrease the flu, and in Australia is like that. But you never know with the flu. You never know with the way the flu distributes itself, the seasonality of it. And so we want to make sure that we protect the public and we protect the healthcare system as much as possible. We don't want to take a chance. We know that, yes, there'll be less flu circulating, but if it does, we wanted people to be vaccinated. As a matter of fact, we had one case of the influenza B a week ago in our area. So, it's already starting. So I'm hoping that we were able to quell it as much as possible. And yes, it might be less, but we can never predict these things. Non, en français, la question est que on prend toutes les précautions de santé publique, sont les mêmes pour nous protéger contre la grippe et que COVID. Donc, pourquoi est-ce qu'on a besoin de vaccin si on va avoir une diminution du grippe? C'est vrai qu'en Australie, où déjà ils ont eu leur saison grippale, c'était moins. Il y avait des cas, mais moins. Donc, nous, on ne voudrait pas prendre chance, on voudrait rassurer qu'on est protégé beaucoup plus de façon importante, surtout les aînés, les personnes aînées, les personnes vulnérables. Et c'est pour ça qu'on on fait la promotion de le vaccin d'influenza.
Fantastic. So, Dr. Paul, we're going to go back to a question that you've already addressed in a previous Facebook Live event, and also in some of your media briefings, but there's still lots of questions about this. So people are still asking, why aren't we prioritizing our testing centers for people who live in the EOHU region? So do you mind repeating again why the approach of it's open to everyone in Ontario?
The testing and laboratory and all healthcare services are financed directly from the Ontario government through what's called Ontario Health. And Ontario Health East funds all hospitals, all clinical services from literally Durham, from Oshawa, all the way to us. And so the policy is that Ontarians can go and get medical treatment where they want. People from the Eastern Ontario Health Unit go to Montfort, go to CHEO, and vice versa. So that's the same policy. We are not able to limit that type of approach to just to our area residents, unfortunately. But I do believe that we have mechanisms now to increase our capacity to be able to serve everybody. Je peux demander pourquoi on ne fait pas une restriction au niveau des tests dans notre région, uniquement aux résidents de la région que nous représente, du Bureau de santé de l'Est Ontario. Et je réponds, c'est très facile. Les fonds du traitement médical, tous les soins médicaux en Ontario sont subventionnés, sont payés pour le gouvernement d'Ontario. Et ils sont payés spécifiquement par, on appelle ça Santé Ontario, Ontario Health East, l'Est, qui commence vraiment à Oshawa jusqu'à nous ici. Donc, la politique du gouvernement, pas juste ce gouvernement, mais avant, c'est que les Ontariens pourront recevoir les services médicaux n'importe où en Ontario. Et donc, il faut respecter ça, on le respecte. Et comme on ne peut pas interdire les personnes de Prescott Russell d'aller à Montfort ou aller au CHEO. Donc, c'est la même chose. Donc, c'est pour ça qu'on ne peut pas, faire une restriction comme ça. Par contre, on reconnaît qu'on a une débit importante. Donc, c'est pour ça qu'on a augmenté la capacité à Limoges et à Castleman.
Thank you, Dr. Paul, for clarifying. Notre prochaine question vient de Annick Lalonde. Donc, la semaine dernière, vous avez dit que les mini-cohortes à l'intérieur d'une même classe étaient une bonne idée pour les classes maternelles jardin. Est-ce que ceci a été discuté et accepté par certains conseils de notre région?
On est en train d'en discuter. J'ai parlé la semaine passée. On est en train de discuter. Hier, j'avais une rencontre avec tous nos infirmières, les 12 que nous avons engagées récemment pour l'école, pour en discuter. Donc, on est en train de voir dans quelle école ça pourrait bénéficier, dans quelle école ça pourrait marcher. Donc, on est en train d'en discuter, oui. The question was really something I said about in the younger children, where if you have a lot of kids that you may be able to put four together, and not mix with each other. And the question was, have I discussed it with the school boards? And I said, the answer is yes, I have. As a matter of fact, I've actually discussed it and looked at all the schools with our 12 new nurses. I had a meeting yesterday with them where I've asked them to list to us the number of kids in the schools and what they're doing to separate them, what the distances are. So then we can look at the different options, including that one.
Fantastic. Thank you, Dr. Paul. So we're going to switch gears a bit and start. And there's a question about businesses. And so are businesses still supposed to limit the amount of people allowed inside? And is the EOHU looking to do checks at local businesses to make sure that they're still following and implementing the public health measures like crowd control, following the masking directive, or even having like directional arrows to move people around safely?
Yes, those measures are still in place. As a matter of fact, I have a Section 22 order. There's an order with big penalties that if they don't follow them. They're very strict guidelines that we have for them. And there is a limitation to the number, although there's no strict number of limitation to a premise because it depends on the size of the premise. We do have limits, for example, in terms of you can't put more people than you in an area where you can't physically distance them. So we do that. We do spot check sometimes, but we do get some complaints, and we do follow up on the complaints. We've had less complaints now, but we do calls, and we will certainly be able to enforce those things. And yes, those are very important to be done. The masking is also an important part of it as well, because even in the best, if there's the best type of directions, you might make a mistake and go face to face with somebody, like by accident. So that's why we want to put that in as well. But certainly we have an expectation. There's minimum expectations. There's a checklist that's on our website of what we expect them to do. And if anybody sees that those things are not followed, let us know. We will follow up. La question est que est-ce qu'on a des limites au niveau des personnes qui pourront rentrer dans un commerce? Et la réponse est oui. On n'a pas un chiffre en général, c'est parce que ça dépend le format, le grandeur d'espace, mais on a d'autres précautions. En effet, il y a un ordre médical que j'ai fait, un ordre légal que j'ai fait, qui donne une liste des choses qu'on s'attend qu'ils font. Il faut avoir un contrôle à la porte, il faut avoir désinfection, il faut avoir les consignes, les plexiglas, etc. Pour le moment, on en reçoit de temps en temps les plaintes et on fait une investigation pour que ça soit réglé. Il y a des amendes pour ça si nécessaire. Mais si quelqu'un... donc, on attend toujours ces précautions de santé publique sont obligatoires dans tous les commerces de notre région. Et si quelqu'un voit ou pense qu'un commerce ne suit pas les directives, il s'agit de nous appeler. On va faire un suivi avec nos inspecteurs.
Fantastic. So, Dr. Paul, there's a little bit of, I think, confusion about the amendment to your Section 22 order relating to masking in food and drink establishments. And so can you clarify what the amendment was intended to be?
Yeah. It's a bit, maybe I want to clarify it. I'm going to be meeting tomorrow with our staff and our lawyer just to maybe make it clear, but this is the bottom line. The bottom line is that when you go into a restaurant, okay, what we're saying is it's an indoor premise. You should be wearing a mask. And so we'll talk about the patrons. We'll talk about the customers. You should be wearing a mask, sitting together at a table. And when you're eating, you take the mask off. The waitress or waiter who's not in your social circle, is not your bubble, will come very close to you to serve you. There's not going to be 2-meter distance. So we expect, and they do because it's indoors, they should be wearing masks, as should you when you're being served. Once the waiter or waitress leaves, you can take your mask off and eat. That's not a problem. We have been getting some questions and sort of questions about, well, does that apply in a patio setting in a restaurant? Okay. The only difference there is that you're outside, but you're still sort of enclosed space and you're still getting served face to face. It's hard for a waitress to serve somebody to, serve your table 2 meters away. So they're inevitably going to get close to you. So we put that order in to make it clear that in those situations, the waitresses or waiters or busboys, whoever is servicing the table should be wearing a mask. And that's why we put it in there. It's been a bit confused, but we will clarify it. La question est que nous avons changé un peu nos guidances, une ordonnance que j'ai faite pour les masques, surtout au restaurant, etc. Je vais vous expliquer les questions qu'on avait. Normalement, avec nos directives des masques, on dit que les personnes qui rentrent les clients qui rentrent dans un commerce. Dans cette situation, c'est un restaurant. Et les employés, donc les serveurs, etc., devraient porter des masques. Une fois qu'une table, disons que vous êtes là avec votre cercle social, vous allez vous asseoir, vous portez vos masques. À un moment donné, quand vous allez manger, vous allez enlever votre masque pour manger. Très bien. La serveur ou la serveuse qui va vous servir ne peut pas être 2 mètres de distance parce qu'elle va vous servir vos repas. Donc, dans ces circonstances-là, en effet, c'est logique et en effet, ils le font. Dans les restaurants, dans l'intérieur des restaurants, les serveurs, les employés portent des masques. Et quand il va vous approcher, vous allez porter votre masque. À un moment donné, le serveur va vous donner vos aliments. Vous allez enlever votre masque ou aller manger. Nous avons des questions. Est-ce que ceci s'applique dans les patios des restaurants? Parce qu'ils sont à l'extérieur, ne sont pas à l'intérieur. Par contre, il y a quelques murs, ce n'est pas comme l'intérieur comme tel, mais vous êtes servi encore. Vous êtes face à face, des fois avec une serveuse ou d'autres personnes. Donc oui, ça prend un masque dans ce contexte aussi, au niveau des serveurs. Ça, c'est la question qu'on avait. Donc, je vais le clarifier demain. Je rencontre mon équipe demain pour le clarifier, mais ça, c'est l'esprit avec lequel on a donné cette ordonnance.
Fantastic. So the updated order should be back up on the website shortly with the clearer language.
Clearer. It was really meant for those type of settings because we had a lot of people saying, well, should I wear it in the patio or not?
Perfect. Thank you. So we're going to switch gears a little bit. You mentioned it a bit in your intro, I believe, or maybe it was today during your media briefing, but it was mentioned that some of the more recent cases stem from backyard parties or gatherings, most likely tied to the Labor Day weekend. But we had someone who was wondering if you're able to comment on whether or not there's any cases that have been tied to protests or demonstrations.
Okay. Well, I can tell you that we followed it closely when we had the demonstration in Cornwall, and my colleagues in Ottawa as well, that have not had one case that came out of those demonstrations. A lot of them were wearing masks and they were outside. And that's a different context, than what we're seeing in backyards. And so, no, we have not seen cases there, but we've seen cases in people's backyards and private parties, indoor or outdoor as well. It has to do with the proximity with which you're somebody, the length of the contact, and the number of people that are sort of crammed in together. So, and in the outside demonstrations, there's a lot of people, but I know they're crammed. So we didn't get any cases, either us or Toronto or Ottawa, to my knowledge, of any of those demonstrators. But I know they're all wearing masks. Where we get the issues is people have 20 people in their home or 25 people in their home. They don't mask. They don't physically distance. Sometimes people go to the parties with symptoms, which we've had, and they spread it to others. So that's what we're seeing. So we're not seeing it in demonstrations. We're seeing it more in those backyards. La question est, est-ce qu'on voit, c'est vrai qu'on voit la plupart des cas dans des parties privées, de barbecue, des anniversaires, des choses comme ça. Et est-ce que la question, est-ce qu'on a vu une augmentation des cas reliés aux démonstrations qu'on avait je pense en mois de mai, je ne me souviens pas, du Black Lives Matter, qu'on avait à Cornwall et aussi à Ottawa et à Toronto. Je peux vous dire, pour ces démonstrations, la plupart des personnes portaient des masques quand même, mais on n'a pas aucun cas, ni nous ni Ottawa, qui était relié à ces démonstrations. Par contre, les cas qu'on voit sont peut-être 10-20 personnes qui se rencontrent ensemble. Ils ne portent pas les masques. Ils ne sont pas distancés de tout. Et à un moment donné, une personne infecte l'autre et puis on pourra avoir 3-4 cas reliés à ça. Donc, ça, c'est la différence et ceci, c'est ce qu'on voit. Donc, encore, c'est pour ça que les règlements ont changé. Il faut limiter le numéro de personnes qui sont en contact avec, dans un espace de l'intérieur, parce qu'avant, ce qu'on faisait, on mettrait 20-25 personnes. Parce que ça prend plusieurs choses pour ce virus de se propager facilement. Une, c'est la proximité. Deux, c'est la durée. Et trois, c'est beaucoup de personnes ensemble. Les virus aiment ça, aiment les trois. Donc, si on met 20 personnes dans une petite cave ou une salle ou un patio ou quelque chose comme ça, le virus va se propager.
Thank you for clarifying, Dr. Paul. We're going to go to a question from the chat box from Beth Ann. So we're going back to testing. She wants to know, can Quebec residents be tested in Ontario and vice versa?
They can. It's a bit more complicated because the results have to go back to where they live, but they can. I know that they're getting tested in Hawkesbury, and I'm not sure if Ontario residents get tested in Quebec, but I presume they would. Je ne sais pas si les Ontariens pourraient être testés à Québec, mais je peux vous dire que les Québécois pourront être testés ici. C'est un peu plus compliqué parce que il faut qu'on amène les résultats à leur province.
Thank you, Dr. Paul. We have about 10 minutes left, Dr. Paul. So there is a question from Maria Abul Osan Labrec. And so I'm going to paraphrase, but basically asking if you can talk a little bit about the reality of COVID not going anywhere, and do you expect it to be similar to the flu, the seasonal influenza? It's something that we see frequently, and how we anticipate kind of moving forward long term with living with COVID, eventually, hopefully having a vaccine, just kind of how are we going to continue living with this, and maybe kind of giving a bit of context to everyone.
Well, good. Well, that's a very good question. And, we compare it with the flu. And, we are very familiar with the flu viruses. The flu viruses have been around for years, infecting humans. And, they might change a bit. They might mutate. So we need different vaccines. But we do have a vaccine, and we do have effective treatment for the flu viruses. Now, this COVID is a coronavirus, which in its cousins, if you like, infect humans and don't cause many problems, just cause colds. This virus mixed with animal type viruses to create a new type of virus that we've never seen before. Our body has never seen anything like this type of virus. And so a lot of people who, particularly live through many years of the flu, eventually, if they see a relative of that virus, they may be able to have some sort of protection. And we'll boost it with a vaccine every year. And we also have medications. In this situation, this is a new virus of which 99% of the population has not seen. And so it spreads to a lot of people. And until a certain amount of people are immune to it, either by getting the virus or by a vaccine, the virus will survive. So, we don't want 100% of people being infected. That's why we're waiting for a vaccine. And a vaccine will come out likely next year that will vaccinate the majority, a lot of people. And so as we vaccinate versus that vaccine, that virus, we believe that we'll be able to make that strain not dangerous or not able to infect a lot of people. That's what we believe. We don't believe this virus would change. We hope not, but we do. Unlike the flu virus, this virus has not changed. The flu virus changes a lot, but once we have a vaccine that's effective for one strain, we'll be able to do another. But it's the first time that we've had to make a vaccine for this virus. So what's my prediction? My prediction is that we're going to be sort of in and out, up and down until we have a vaccine. Once at that point, you'll have the number of people who are vaccinated, number of people who have had it. Those will cause what's called herd immunity, and the virus will not go away, but it won't be a significant issue. That's what I think is going to happen. I can't guarantee it. Timelines, I'm not sure, but certainly into next year. And it depends on when we get the vaccine and those type of things. Now, and this is a different virus as well, and we're learning about this virus day to day. We're learning about how it infects people. We're learning that, unlike the flu, okay, it gets into the blood and it causes blood clots, it causes kidney failure, causes heart attacks, and now we know it even causes stroke, which are not characteristics of the flu. So it's a different type of virus. But again, if it behaves like other viruses, like for example, we have hepatitis A, hepatitis B, we have effective vaccines that once you get a vaccine, and you get antibodies, you're protected from it for life. So I predict that's what's going to happen with this one, but it's because right now it's infecting so many people because it's what we call it, we're naive to it. In other words, we've never been exposed to it. So I'm going to try to say it in French. La question était, qu'est-ce qu'on prévoit à long terme avec COVID? Est-ce qu'on va avoir de COVID pour des années? Comment est-ce que ça va comparer avec l'influenza? Premièrement, l'influenza, on le connaît bien. On a variées souches d'influenza qui infectent les humains. Ça fait des années. Et aussi, il y a des personnes qui disons qu'on était exposé à un type de virus d'influenza, malgré que ça a changé un peu. On a un peu de protection. On a les anticorps qui le reconnaissent, qui peut nous protéger. Peut-être pas à 100%, mais il va le protéger. Le virus de COVID, ça vient du famille de coronavirus. Et cette famille, on est familière, c'est la cause du rhume. C'est très facile. Les formes qui habituellement infectent les humains sont légères et il n'y a aucun problème avec. Par contre, ceci est un virus qui a mélangé avec d'autres virus des animaux et qui a des attributs et qui est complètement différent. Donc, si quelqu'un qui n'a jamais vu, notre système immunitaire n'a jamais vu ce type de virus, on pourrait toujours, on n'a pas des anticorps, donc on va être infecté. Donc, la plupart des gens, 98% des gens, ils n'ont aucun anticorps, ils n'ont aucun système immunologique naturel pour le protéger. Donc, la seule moyenne qu'on pourrait se protéger, soit que tout le monde va être infecté à 100% ou 80%, et à ce moment-là, le virus n'aurait pas de place parce que tous les gens qui étaient infectés, ils vont être protégés. Ou on vaccine beaucoup de gens avec le vaccin qui, on espère, va être là l'année prochaine. Et à ce moment-là, il va y avoir assez de personnes qui vont avoir la protection communautaire. Et le virus ne va pas se propager et ça va s'en aller et on n'aura pas beaucoup de problèmes avec ce virus. Moi, je ne pense pas que ce virus va changer comme l'influenza. Et comme on a d'autres virus comme hépatite B, etc., ceci ne change pas. Un vaccin suffit pour vie. Donc, espérons que ça va aller comme ça. Mais c'est ça que je prévois. Je ne peux pas vous garantir. Et je peux vous dire qu'on va être dans ce contexte comme on est maintenant, avec des pics, avec des bas, hauts et bas, des cas, jusqu'à temps qu'on a un vaccin efficace. Espérons qu'on va avoir ça tôt dans l'année prochaine.
Excellent. Merci, Dr. Paul. On va prendre une question de Isabelle Courville-Leroux. Elle demande, les étudiants des écoles, surtout secondaires, qui se regroupent sur les trottoirs et à proximité de l'école ou pour marcher à la maison après l'école, a dit sans masque, sans la moindre distanciation physique. Est-ce qu'on a un plan pour adresser cette problématique potentielle?
Oui, en effet, j'ai eu plusieurs plaintes avec ça, avec plusieurs municipalités. On est en train de travailler avec les écoles et aussi avec les officiers civiques des municipalités pour voir qu'est-ce qu'on pourrait faire pour avoir la police pour aller les parler ou des personnes pour donner pour les aviser de faire distance. Parce qu'on voit ça, ce n'est pas juste dans une région. J'en ai pas mal de plaintes à travers de notre région. The question is, we're seeing a lot of teenagers after school, they're just hanging around, no mask, no distancing, and so on. And what are we going to do about that? We've had complaints about that. I've actually spoken to several mayors, several school boards, and we're now working with them to see if we can send bylaw officers or even police just to warn them. Make sure you distance, make sure you don't hang around together, and those type of things. So that is a challenge.
Thank you, Dr. Paul. We have time for one last question. And so this question comes from quite a few people in the chat box, but Tanya Savard was asking about if you can provide some clarity on the instruction about students being able to return to school after they're 24 hours symptom-free, or some are saying, no, it's when they start to improve. So there seems to be a lot of confusion about that directive.
The directive has changed, and we're adapting it to our model as well. Essentially, we want to have 24 hours, no fever, and symptoms improving, both together. That's the clarity.
Pouvez-vous répéter en français?
Oui. Il y a des questions au niveau de quand est-ce que l'enfant, étant donné que le test est négatif, l'enfant n'a pas COVID, quand est-ce que l'enfant pourrait retourner à l'école? Avant, on disait 24 heures sans symptômes, mais là, on a changé. On pourrait aligner avec la guidance provinciale. C'est 24 heures, pas de fièvre et amélioration des symptômes.
Wonderful. Thank you, Dr. Paul. I think that's all the time we have today. We answered lots of questions, so thank you very much. And thank you for everyone who joined us tonight. Donc, merci, Dr. Paul. Vous avez répondu à beaucoup de questions ce soir. Et merci à tous ceux qui se sont joints à nous. And you can always visit our website. And if you have more questions, you can send them in via our Facebook chat box or call us at the health unit. Donc, vous pouvez toujours soumettre vos questions qu'on n'a pas eu la chance de répondre par l'entremise de notre site Facebook ou nous appeler au bureau de santé. Donc, merci beaucoup. Good night.
Good night, merci.